Hello, everyone, and welcome to week 7 of the Stepping into the World of Dementia virtual tour. My name is Tamaria Smith Gillespie, and I am the owner of Royalty Senior Service Consulting. I am again excited about the session for today because oftentimes I find that many people ask me about what is a geriatrician. And I'm excited today because our guest speaker today is Dr. Nakisha Rogers, and she is a geriatrician. And for those of you who do not know what a geriatrician is, I guarantee you by the end of this session, you will have a little better understanding about a geriatrician and how geriatricians can help seniors as they age. Now, I would like to take the time to welcome our guest speaker, Dr. Nakisha Rogers. She is an internist, she's a geriatrician, an author, and a speaker. Help me welcome Dr. Nakisha Rogers.
Yay! Thank you so much, Ms. Gillespie. I am so excited to be here today and to be a part of this tour. I am so excited that you were able to get me on the tour. So we are going to have a good time today. I just want to let people know that this is going to be a very free-flowing opportunity to ask anything you want to ask about us geriatricians. And honestly, I get that question all the time. People are like, what is it that you do? Is it a pediatrician? It is what exactly is that specialty? So this, like you said, will be an opportunity for us to go over the steps in training and, what we offer to what I like to call my sassy and my savvy seniors. So I guess with that said, are you okay for us to go ahead? I could go ahead.
Yes, please start.
All right, so I think that I have control. Okay, so I will just kind of give you guys a nutshell. I like to keep things very simple. So my name's Dr. Nakisha. I am from the beautiful island of the Bahamas. Yes, sun, sand, and sea. And my journey to medicine really started long ago when my mom said I was like 6. So apparently I had this this interest in older people. And she gives the story of me being in this bakery shop. And she kept saying, we give you like 25 cents. So this is back in the 80s. And she'd give me these 25-cent pieces or 50-cent pieces to go get donuts. And she wanted to figure out, her and my father wanted to figure out what is taking this little girl so long to go get these donuts. And come to find out, they realized that I started making a conversation with the owner of the bakery. And guess how old he was? Hint, hint. So he was in his 70s, and it was he and his wife. And I really enjoyed working, listening to them. But more importantly, I love the fact that they took an interest in me. So they would ask me, hey, little lady, how was your day? What did you learn in school? So as me and my mom reflect now, we kind of realized that I guess God had it for me to serve seniors. And that started at the age of 6. So as you know, Ms. Gillespie said, I do internal medicine. And again, I have to explain to people, what in the world is that? So internal medicine is a specialty where we look at you from head to toe. So if there's something wrong, if you're having a headache, if your diabetes is not, well controlled, if your blood pressures are crazy, if you think you may end up on dialysis, we go from head to toe and think of us as like the gateway into if there is a problem. So what do I mean by that? That basically means, if you eventually need to see a specialist, like a surgeon, if you broke a hip, or if you have to go for heart surgery, we're kind of the gatekeepers. So our goal is we're learning the whole body so that we call for backup if we realize that there's a procedure that has to be done. But you definitely want to find yourself a good internist or a family medicine doctor. And then I'll talk a little bit more about geriatrics, but that's exactly what I do. But the beauty of geriatrics, and I think Miss Gillespie, as we were speaking before we went on, it's like, think of us as like a buffet. So it's like an all for one package. So you get one of us, you hit it big because we do everything. And currently right now, I enjoy what I do because I get to, work with these new brilliant medical students who are graduating, and we're trying to get them trained to understand that people are getting older. People's grandmothers, their mothers, their aunts are getting older. So right now I'm at FSU, and I have the opportunity and the privilege to train I call them my babies. So I get to train them in this world of geriatrics. All right, with all that said, Recently, by God's grace, I took a step of faith, and over the years, over 10 years of just working with these amazing seniors and their families, I started to realize that, and even in my own parents, that there were people who were aging really well. And then there were those that were having a bit of troubles. And I started writing, so this is like 10 years of stuff that I noticed. And I kind of compiled it as my secrets of what I found, the ones who were, still really with it, mentally sharp with it. And I tried to put that together in a simple to read format. Again, my parents were teachers, so they always said, keep it simple, keep it direct, make sure people can understand what you're saying. So I think it was May of this year, we were able to really get this out to people. I was so excited. It was a dream of mine, first time publishing a book, and it was really well received. So I would encourage you, if you want a simple, easy to read book about, what to expect as I get older, then I think this is a really nice starting point. And it's My Secrets of the Sassy, Savvy Senior, because they're very sassy. They are very sassy. All right. With that said, so the whole point of today was to answer this question: what in the world do we do? What is a geriatrician? So I guess I wish I could open the floor for questions or comments, but put it in the chat. If you're able to put it in the chat, I want some people to kind of type in the chat, what in the world do you think a geriatrician is? What do you think we do? What ages of people do you think that we care for? So I'm going to wait like a couple of seconds and see if you guys are able to put it in the chat. What do you think a geriatrician is? And many of you may know already, so you may be able to school me on the experiences you guys have had. But yeah, put it in the chat. I am curious to hear, because people practice very differently. So I'd love to hear your thoughts on what a geriatrician does. What do we do? And while you guys are doing that, I'll give you a little history. So basically, the word geriatrics or geriatrics, like I said, it really goes back to like 1891. Jerry being old, and over the years, people realize that people are getting older and older. I'm sure, as you look around, you see people living well into their hundreds. And in fact, there are places in the world where people are thriving well into their hundreds. So you're like, yeah, give me a plane ticket to these places. So yeah, there's actually 5 places in the world, and you could Google this, and they call them blue zones. And these blue zones are amazing. One is actually in the US. It's in California. There is another one closer to where I'm from, like in the Caribbean, a little bit more south, Costa Rica. So that's number 2. There's a third one that's in Italy. So, we have 2 more to go. So I'll let you guys think of those last 2 places where people are living well into their hundreds. And so there's something that these people are doing that we need to do more of. So those are the blue zones. So I gave you guys some time to put it in the chat, but I'll just,
You
oh,
have one response in there from Tawan. It says a doctor that serves seniors as they age.
yes. All right, Tawan. Very good. That's right. So you are absolutely right. So a geriatrician, our goal is like you come to my clinic, the people over 65, I just love them. And in my world, they're my babies. So we take care of anybody primarily from the age of 65 all the way until, the end of life. The way we kind of classify our seniors are, 65 to 74 are like our young old. So they're like my babies. And then, we have the 74 to 85. They're like our older old. And then our over 85 are obviously our oldest old. However, the issue with aging, and as I tell my students, if you've seen one geriatric patient, you've only seen one. Think about your grandmother. Think of, the people that you've seen getting older. Like you cannot generalize, someone's aging process because people do it differently. And aging is affected by so many things. It's like the genetics of the people in the blue zones, as well as, your lifestyle impacts your aging, as well as your environment. So as Tawan said, I take care of people over 65. So what my focus is so as the internist, I'm concerned about the heart attack. I'm concerned about getting your cholesterol well. I'm concerned about making sure that I'm giving you your vaccines and I'm talking to you. Definitely, prevention is key in my world. However, I take a step back from my patients and I kind of focus on function. And you're like, but yeah, every doctor does that. Actually, they don't. And I could give you countless stories of, sometimes you'll get so focused on trying to manage someone's diabetes that you don't stop to look at them walk down the hallway and realize that they're not picking up their feet. They're kind of shuffling along. You don't realize that they're using like the incorrect shoes that don't give support. You don't realize that, what, Mrs. Joe is actually at risk for falls. So my job as a geriatrician is, in addition to managing all those diabetes, high blood pressure, your cataracts, and so forth, I look at the whole picture so that I could prevent that person from falling, so that I could prevent some of these things that we call syndromes that prevent you from really living your best quality of life. So the thing that we teach our students is all about the function. I need you to be able to function. And actually, if you talk to a lot of seniors, the thing, even my parents will tell me, they're like, listen, I am going to be independent. I do not want to rely on children. No one's going to put me in a nursing home. So so our goal is to meet your goals. So for some people, the goal may be, what, I want to be able to cook meals. I want to be able to be functional so that I prevent falls. Because many people may not realize that when people fall, I'm sure you've seen in the news, celebrities falling downstairs and so forth, 30% of those people will actually pass away from the fall. 30% will get better. They'll go to rehab. And then 30% will actually have a steep decline. And within the next year or so, they'll die. So the geriatricians, we step back and we look at the things that other doctors may ignore. The fall risk. We look at the fact that, patients have memory issues. We look at the fact that incontinence, that's not a normal part of aging. So whereas the other doctor may say, oh, Miss Joe, yeah, you having to go to the bathroom, you have a weak bladder, it comes with age. And actually, that's not really true. So our job is to really optimize function. And then one of the things that we do, this is a team sport. So I always credit and give support to the people who help me. So you have your nurses, you have your social workers, you have your physical therapists. Like, you need a team to manage a geriatric patient. And so our goal is, we have our team that works with the patient, and the big player that we always try to involve is the caregiver. I can't tell you how many times, I've seen daughters break down in tears. They'll come in the room, they'll sit with us, they're kind of quiet as we're talking to the patient. And then you'll kind of get a sense that they want to share more. And the minute, this is classic, you're going to reach for the door and like, okay, Miss So-and-so, I'll see you next time. And then as their mom or their dad's leaving, they'll touch you. Hey, Dr. Rogers, I need to tell you something. She's not being truthful, but we have a lot to discuss here. So our goal as the geriatrician is to really work with the family and with those caregivers so that we could give you a plan, because things happen. I mean, COVID taught us that there's nothing that we can never say is impossible. So you have to have a plan, and you have to have caregivers by your side. So our goal is to work with you, your family, and help you to function, in a nutshell. All right. Woo. Okay. Got to take a breath. All right. So how do we get there? So everybody knows Oprah and Gail. They were all over the place years ago taking this road trip. So I want you guys to picture it. And honestly, right now in the US, we really need people taking care of seniors. There's only about 7,000 of us. And they are saying by 2030, the demand is for at least 30,000. So imagine 7,000 right now. And we need about 5 times the amount of that. And so if you have a daughter, a niece, or someone that's really into medicine, and, you realize they have a passion for older people, maybe consider nudging them into, maybe visiting a rehab facility or talking to one of us, because we really need more people that have a passion and that really have a heart to help people age and are staying current in this field. So how do we get there? So I shared a bit about my story, but as with all stages of medicine, you do an undergrad degree. So that could normally be in like biology, chemistry. You pick your undergraduate degree. And then there is the whole, oh, I got to get into medical school. Now, some people do different routes. You could do the US route where you are doing your MCATs. I came from the Bahamas, so I did my route through the Caribbean, but I eventually made my way into America. Um, but you have to go through medical school. And then your second destination after you've gone through, high school, your undergrad degree where you got your bachelor's and you did your medical school, then it's the time where you need to get specialized training. And that's what we call a residency program. So there's so many residency programs. Like where I'm at is like Florida State, but there's tons and thousands of programs. You get into a residency program, and during 3 years, some programs are 4 years, but if you do internal medicine, like I said, we are drilled from head to toe. So we're working in the ICU, we're working with surgeons as well. We're working on these different rotations with the kidney specialists, with the lung doctors, with the stomach doctors. We're working with all of those in an effort to get us to have a basic understanding of how everything functions. And then at the end of that, those 3 grueling years, we have to sit this exam. So it's called our American Board of Internal Medicine exam. We got to sit in front of this computer screen for like 8 hours, answering close to 300 questions. And so, you have to prepare for that like throughout your training. You don't want to cram for that. So once we get through that residency program and we get board certified, we're so excited. We're like, yes, thank you, Jesus, it's done. But doesn't stop there. So once you do your residency program and you're board certified in internal medicine, remember, like I said, you need to add a little bit more. You need to be a specialist. So other specialties, I'm sure you guys have heard, everybody hears cardiology, pediatrics, obstetrics and gynecology, psychiatry. Nobody shouts us out. I'm like, where is geriatrics? I have my own cheerleader. But there is, after we graduate, we do also have specialized training. And that specialized training is for about a year to 2 years. So what's the difference? So in the fellowship program, you could do it's a year where we get to see seniors in all these amazing settings. So you would see them in nursing homes. You get to see them really at outpatient. We used to make home visits and check on them. We would also do these visits to something called a PACE program. And actually, they're pretty common. They're like in Boston, Florida. And you're probably wondering, well, what is a PACE program? So this is a program of all-inclusive care for the elderly. And it's a program where patients who may be dependent on, like, say, preparing their meals, doing their laundry, etc. They have more functional dependence. We want to stave off, them having to enter a nursing facility. So they had this wonderful idea, like, why don't we bring these patients together? And from, like, say 9 to 12, we bring them, we give them activities. We have a nurse on staff. We have their medications there. We have doctors to see them. We have physical therapy programs. It's really, really good. And when I trained in Boston when I did my fellowship, and it was really nice. It was almost like a camp for seniors. But they had the medical staff there. They had the physical therapists there. They were playing their Wii's. They got their meals. And this was a way for us to prevent, patients who, the kids have to go to work. So at least, your mom's taken care of. So we got to see patients in all these different settings, nursing homes, PACE programs, in their homes, in the hospital. And we also got to be the ones where we would decide, is this person, safe to have a procedure? But around the time that I, had trained, there was this new thing coming out in the market and in Boston. And this was a procedure called a TAVR. And so we were excited because the surgeons would partner with us, the geriatricians, so I'll explain what a TAVR is. So a TAVR is basically if somebody you have your heart, and your heart has 4 chambers. So one of the valves that actually pumps all the blood to the rest of your body is called your aortic valve, right? Just think of it as a door. If that door gets stuck and there's no blood to get out to like your brain, you'll get dizzy. So people will sometimes complain of, I feel like I'm going to pass out. If there is no blood that can, move forward to the other parts of the body, the patient may have, shortness of breath, and they can also develop chest pain. So when that aortic valve isn't working, years ago, the one of the ways that we would fix it is literally, crack your chest open, crack it open, for lack of a better term, and go in there and replace that valve. But years ago, about 10, 12 years ago, they came up with this amazing way where people in their 80s and 90s were able to avoid such an invasive procedure, because people were scared, like, I don't want to have my chest cracked open. So they decided, what if we were able to put a new valve and not cut their chest open, but maybe go through one of the veins in their leg and kind of like snake it all the way up. And that was called a TAVR procedure. So, families were excited because they're like, oh my gosh, my mom could get this done. And we don't have the risk of a lengthy hospital stay. We don't have the complications of, them getting an infected wound from the cutting the chest. And so who did they come to? They came to us, and they were like, we got these 80-year-old lovely young, I call them my young ladies, these lovely young women. And we need to know, what is the risk of something going wrong on the operating table? What is the risk of something going on afterwards? So this was amazing that we came up when this came out. And so I remembered having to check people's memory, because picture it, if they're going through your legs and trying to put this valve in, if they're trying to replace the old valve, sometimes as they start poking stuff around, pieces of plaque can get loose. And if those plaques get loose, one could go to your brain and cause a stroke. So the geriatricians, we came in getting you pumped up for the surgery. We would do memory tests because we wanted to make sure that, post procedure, there wasn't a change in your memory that, the procedure caused. We wanted to make sure that you had the functional capacity. We wanted to find out what was important to you, like what exactly you wanted to accomplish by this procedure. Some people said, you know what, I just want to be able to have enough stamina so that I could stay in my home, have enough stamina to make my meals. So we take short-term goals and we run with them. So within a nutshell, that's what the fellowship program does. So you meet with seniors in all these different locales. You learn how to cope, you learn how to manage their diseases, and you learn how to work with families and specialists. If you do an additional year, some of my colleagues did an additional year, you do a research project. So you could do whatever suits your fancy, but we all know that Alzheimer's is like the big thing, everybody. We're still trying to find a cure. So you could do projects on Alzheimer's, on osteoporosis, you name it. So the 2-year program involves an additional year of research. I did the clinical path where I really wanted to see them in a year and then focus on how I would care for them in these different settings. And that is what we call a geriatric fellowship. So do you need one? So people always ask, well, Dr. Nakisha, I got a family doctor, I got an internist. Why do I need you? Why does mom need you? And I tell them, like, even myself, by this age, by 2060, 1 in 4 people in America is going to be 65 or older. So this is something, people are living longer. That's in part to the advances in medicine, to vaccines, etc. But people are living longer. But we want a quality of life that's healthy longer, not living longer to languish. So it's really important that, I think I mentioned before, there's only 7,000 of us and the demand is for 30,000. So you have one geriatrician trying to service this whole, group, trying to service this whole community. So you want to definitely, consider having someone that has that extra training for your grandmother, that can kind of understand the changes in normal aging. So what do we do in a nutshell? Again, we are big on, I always say the ounce of prevention is better than a pound of cure. So I know a lot of times, and I was guilty of this before I became a geriatrician, patients would say, well, that's normal, you're hearing, you're losing your hearing, or you're feeling this ache and pain. They'll say, oh, that happens. That's supposed to happen with me. I'm getting older. Some cases it's true, in some cases it's not. So our goal is, I tell my patients, even though you may be 75 and the average doctor may say, we're going to stop all these screens. we take it a step further. And, certainly we're not going to push for like procedures that will cause you more harm in the end. But if we, again, I go back to function, we have ways that we could plug in our predicted, we're not God, but we have ways where we could plug in your predicted life expectancy. So we think that, you know what, I think Miss Jo is going to live an additional 10 years. She's like walking every day. Her cholesterol looks better than mine. So I'm not going to deny her a mammogram, a bone density scan, simply based on her age. I want to look at the function. And that's why we're so heavily steeped in function. So if you were to see somebody else, they may just say, you don't need that. We're stopping everything. But at least with us, we have the conversation. So we're big on preventative care. That is our thing. The other thing is, and I am a big advocate of this, I cannot tell you how many times people end up in the hospital, and seniors tend to stay longer. I mean, think about it. This is a new environment. The machines are beeping all through the night. People are coming in 12 o'clock in the morning, 5 o'clock in the morning, drawing blood, taking labs. It can make anybody confused and delirious. So what we like to do, I like to get my patients, first of all, I don't want you in the hospital, but life happens. And if something should happen, the geriatrician is there to help you navigate these complex stays. So number one, we always make sure that you're up to date on your advanced directives. We always make sure that these things are updated regularly when things are good. Because I cannot tell you how many times people will be admitted to the emergency room. You're huffing and puffing and everybody hates to hear, well, Miss So-and-so, if we have to ask, if something should happen to you, if this doesn't go well, what do you want us to do? Of course, help me. So you never want to wait until there's an emergency and people are asking you because you're not thinking. And even sometimes daughters, your sons, you're confused. And so our goal is when things are good and you're just seeing us on a regular basis, we update those advanced directives so that you're in a clear head and a clear mental frame and you're not, panicked. You don't make a rush decision, or conversely, you don't receive care that you definitely said, I do not want this done. We also teach we teach families, we teach patients, like my patients know if they're in the hospital. Actually, my students, they'll laugh at me because I'm like, As soon as we march in that room, of course, we introduce ourselves and so forth, but they know, Dr. Rogers, we got to get those patients out of bed. So the last thing you want to actually do, of course, you see your grandmother like, oh my gosh, I don't want to take her out of the bed. She's here in the hospital. She's sick. She's resting. But no, if they're able to get out of the bed, you want them out of the bed into the chair. One thing I always tell people, one day of laying down in the bed puts your body about 2 weeks behind in weakness. So imagine being in the hospital for 3 days. That's the equivalent of like we've lost 6 weeks here. So get out of the bed, even if it's, with safety, obviously get the nurses involved, but, make sure you get those catheters, those Foley catheters out if you don't need them. So we try to teach you these things so you could know what to look out for and, try to get out of there as soon as possible. And then our focus is like, quality of life. I've had patients tell me, I just want a good quality of life. I've worked all these years. I've put people through college. I have sacrificed, and now is my time, and I agree with that. So I look at it as an honor to make those things come true for you. So our goal is to promote, getting you, there's still so much that seniors have to offer. I mean, many times they will, and people know when I give presentations, I'm very, very, very see-through. I've had patients just sometimes they'll turn the clock on me and ask me, now tell me about you. What's going on with you? How is this and that? And very personal questions I cannot share on this. But that's what I love about seniors. They're like, look, I live my life. I don't have time to cut around the bush. I'm going to get to the point. But that's what I love, their authenticity, and they just get to the point. But our goal is to just promote that function, making sure that they still have lifelong learning, going to senior centers, mentoring, keeping up with technology, and that they have a good quality of life. And that's what we keep pushing for. COVID taught us that, when I noticed a lot of seniors really spiral down when they lost that communication. So people were huddled by themselves. They weren't able to go to these senior centers. Not only did they lose muscle mass and, got more frail, but just, their mental sharpness. I saw a decline in that. So our goal is to, get people around each other, with under safe conditions, and just have them know that this is just another exciting stage of life where you get to pour into people. That's what our job is too. And obviously, so with that said, you know what? My goal is to see the big picture in an older person. Like, the cardiologist is like, my goal is to go in there and, put the stent in to open up the clogged artery. But my goal is, why are we putting the stent in? Like, what are we trying to achieve? We're trying to achieve a better quality of life, better function, time with the grandchildren, maybe, making it to someone's wedding. So I look at the goals, like what are we trying to do here? So I step back, you tell me your goals, what you're trying to achieve, and then we work together as a team. Whew. And I think that's it in 30 minutes. Thank you all so much.
All right. Thank you, Dr. Nikisha. Um, if you have any questions, because this is time for you to ask Dr. Rogers any questions that you may have, you're welcome to put them in the chat at this time. I appreciate this wealth of information. It was very informative. Miss Liliana stated that she was really enjoying you and you were very informative.
Oh, thank you. Yes.
You really explain what a geriatrician is, the benefits of having a geriatrician on your team. And just to piggyback off of what she said, it is very important. It's good to have a geriatrician. Just a quick story. Myself, my parents are seniors, and when they moved to Texas, I suggested to my mom and dad, why not get a geriatric doctor, geriatrician. And so they never heard of one before. So I kind of explained briefly. Yeah. And so my mom now has a geriatrician in Texas that she loves. And she really caters to her needs as she's getting older. So like she said, geriatricians, they can help to promote good quality of life as you age. And they have that extra specialization, like she was speaking about, to address the various issues that may come about as you age. Right. So it will be very beneficial. And just to hone in on dementia, geriatricians, they are very knowledgeable in helping you to address the various behaviors that your loved one may exhibit when they're suffering from dementia. Oftentimes I've found many caregivers don't understand about how to handle the various behaviors. And sometimes I guess maybe Dr. Nikisha Rogers could elaborate a little bit on that, the reasoning behind some of the behaviors and how a geriatrician can kind of, help in that area.
Oh, sure. So one of the things we always explain to people is, so when you hear the word dementia, some people use it interchangeably with Alzheimer's. But I tell people dementia is just a big umbrella. And under dementia, there's different types. It's just that you hear about Alzheimer's because it's the most common. But people, it's not an old person's disease. In fact, there are people in their 40s that are being diagnosed with dementia. So there's early onset types. So basically, let me keep it simple. So when I use the word dementia, all I'm saying to you is this is somebody who has cognitive or problems that prevents them from being able to function. So a lot of that stuff, that word keeps coming up again. So how do we determine that? So we give patients a screening test, a screening tool, and that screening tool looks at different parts of your brain. So for me to drive, I use the frontal part of my brain. For me to remember words, remember people's names, I use another part of my brain. So we call those parts of the brains, for lack of a better term, domains. So the issue with dementia, although people tend to think it's a memory problem, that's actually a myth. You could have dementia and it may not affect your memory. It may affect your ability to plan a function. It may affect your ability to speak. So once we see that there's at least 2 of those domains affected, and it's affecting your ability to live independently. So the fact that once this affects, I can't remember how to cook. I can't remember how to drive. I can't remember how to dress myself, bathe myself. Once two of those domains are affected and then your function is impaired, that is when we use the word dementia. So a lot of people will say, "Well, I forget my neighbor's name and stuff. Is that dementia?" So I will tell them, if they're still functioning in the environment, that's fine. We call that like a mild cognitive impairment. So, but you're not out of the woods, because some of those mild cognitive impairment patients can down the road actually develop dementia. So again, that's another plug for a geriatrician. Our goal is like every year, do the testing so that we could pick up if more domains are being affected. To your question about the behaviors, yes, the behaviors tend to be one of the most disturbing things that causes patients and families to get really to the point where I need to put my loved one in a facility because it becomes too much. Um, One of the things that we teach with the behavior is, a behavior is basically the patient with dementia. Think of yourself. I always tell patients, think of them as children. So it's like they're trying to express something to you. So it's just expressed, be um, just an expression of something. And you need to sometimes become a detective and figure out what they're trying to communicate to you. I've had patients complain, that mom's just walking up and down, or mom's just constantly, hitting stuff. So sometimes they'll have flashbacks to what they did as their job. Sometimes they may have pain and they have no other way. They lose the ability to remember the way to communicate that to you. So that may be an expression of, I'm in pain. It can be as simple as, what, I may be constipated. I mean, that may sound kind of, no, that can't be. So, but yeah, so sometimes we become detectives when the behaviors are there, and we try to always look for the cause, whether it be they're not sleeping really well, whether it be they have pain and they just can't tell you about the pain, whether it be sometimes they're just bored and they're just not stimulated. And you think of a child, they're just sitting there. So I'm like, I'm just going to hit on this because you guys don't have me in anything that's structured. So a lot of times I always say, start backwards, figure out what they're trying to communicate to you. And then once you do that, then you could determine, what are the changes that I can do as the caregiver so that I don't stress them out more. Because I know one of the things that people get so frustrated with is, she keeps asking me the same thing. But if you respond back with that, they tend to feed off of you. So if you get all tight and anxious and overwhelmed, then they're going to kind of lash back with that. So just change the conversation. Okay, mom, that's true. Don't argue back with them. Think about yourself. Like, would you argue with a 3-year-old, or would you say, that's true, that is true, and then you just change the conversation? So there's like nice little techniques that we use, that we teach, to help caregivers not become so stressed out, to kind of do reminiscence therapy, where I know there was a case where there was somebody who used to be a nurse in a nursing home. So what they would have her do, in terms, she used to walk a lot. So one of the nurses realized from the family that, oh yeah, when she was in her early years, she was a nurse. So they would say, you know what, we need to walk this energy out. So they had her say, okay, Ruby, we're going to do rounds now. And so rather than just wandering aimlessly, Ruby looked forward to it, because she was just going along thinking that she was doing rounds. So it's really, really getting to know the patient, know the family, figure out what they're trying to communicate, avoid medications if possible, like meds. Those meds have side effects. Okay. So the FDA has put some warnings that if we have to use them, try to use them for short periods. Don't leave patients on if you could avoid it. But definitely, try to figure out what are they trying to express and go from there. I hope that was helpful.
Yes, it was. Thank you. And there's a question in the text, the chat, I'm sorry, from Tawan. It stated, you stated that the longer a person stays in bed, it's an equivalent of 2 weeks. I believe that as he talks about his mother who's bedridden and has not used the muscles in her body for a period of 2 years. He wants to know, can it possibly be reversed with her, that she will be able to do this, although it's been about 2 years?
So I think nothing's impossible. But I think the point would be to, have someone come in, even if it's just like an evaluation from like a home therapist, And maybe we may not be able to get her how she was 2, 3 years ago, but whatever function she has. So maybe she's able to still lift the spoon to feed her, to feed herself. So your goal to one is to, get some physical therapist in there, an occupational therapist, and still use what you have to maintain what you have, so you don't continue to see a decline. So that may be, having her sit in the chair daily, having her, get one of those little squeeze balls and use the muscles in the fingers and so forth. So I definitely tell people, try your best to, get with a therapist, get with an occupational therapist, and at least do the evaluation to see what you can try to prevent. That's a really good question. And also, too, he needs to make sure that he is checking that skin, because as they're laying down in the bed, and I'm sure, he's probably taking really good care of his mom, but make sure, you're all, every day checking those pressure points, like the back of the lower part of the back. Some people even forget like their heels. A lot of times when the heel hits the sheet, that's a source of ulcers in the heels. Even behind the ear, sometimes could be a place where the skin could break down. So make sure that she's being turned, but definitely getting in and out of the bed and getting a therapist in the home.
Okay. Um, all right. Well, thank you. I hope that answered your question. Um, Thank you, Dr. Rogers, again.
Yeah.
Do you have, can you please let everybody know a way that they could, because I know you have a book out,
Oh, yeah.
and
So
could
thank
you
you.
let them know information about ways that they can possibly get that book? And I think you have an Instagram or something
I do.
where they
I
can go
do.
and.
So that is, so I have a team. One of my team members is on this chat today, but we put up content on Facebook, Instagram, and it's at Dr. Nikisha MD. And these are just little reels and stuff to teach patients or teach caregivers, give them education. We try to put something up at least once or twice a week at minimum, but sometimes we'll put up even more. So if you have somebody that takes care of seniors or loves seniors, whatever, please share this link. Follow me on Instagram, and there you can put your questions. So like, hey, Dr. Nikisha, could you talk about this? Could you talk about that? So it's at Dr. Nikisha MD. You could follow me there, and I think the book that I mentioned was in the earlier slide. That book's on Amazon. It's really cool. It's a really good book. So this book was Secrets of Sassy Savvy Seniors. And so through it, I try to take out a lot of the medical jargon, and I explain to you, why you have to get your cholesterol checked, and what is the cause of the high blood pressure, and, what are the different types of dementias. Because I'm a big believer in that people perish for lack of knowledge in Hosea. So I'm all about like be able to defend yourself, be able to speak to your doctors, be able to use the terminologies just to fight for your families. But you can't do that if you don't know what to ask. So this is just like a good reference guide. I have a little small one right next to me. It's really easy to read. That's it right there. It's really easy to read, but it's, written in layman's terms, and it's a good starting point just to have the conversation with your doctor. Like, hey, should mom be getting this? So you could get that that's on Amazon, The Secrets of Sassy Savvy Seniors. And that's it.
All right. Dr. Rogers, I have one other question. If someone wants to find a geriatric doctor or geriatrician, what exactly, because I know some doctors say, okay, I'm a geriatric doctor, and I know you have to have that extra specialization to be classified as a geriatrician. So what exactly, I guess I'm asking right, should they look for when they're researching, okay, trying to find a geriatric doctor in their city or state if they're not located in Florida?
Oh yeah, that's a good. So I'm a part of this American Geriatric Society. So you may want to, Google them, American Geriatric Society, but definitely, so geriatricians can be internists or family medicine doctors, but you definitely want to make sure that they did the extra specialty. And because I said it's only 7,000, so some places may just not have them available readily. As long as you have the knowledge and you start to ask the questions, just make sure that your doctor, because we're teaching more doctors, the things that we do. So just make sure your doctor isn't, skimming through the geriatric needs. So, ask them like, when's the last time you checked mom's mental function? Did you screen mom for faults? Like, you know how to do it. You know how to do it. But you just make sure, even if you stick with your internist, you stick with your family medicine doctor, that you start to see a difference in that, they're just not checking off boxes and not paying attention to the fact that, oh my gosh, in like 5 years, somebody should have told me that, my mom's memory was kind of declining, or somebody should have told me that, she should have gone for some physical therapy, or someone should have told me that we need to downsize this house. Like the geriatrician is kind of thinking practically to help you. So even if you can't find one of us, I would say go to the American Geriatric Society. That's a good starting place, because you could see where we're located. Um, the speak with your physician and just ask them geriatric based questions about quality of life, about risk factors, just to kind of pick their brain, to at least know that they're receptive to it. And if you go to someone and they're just kind of one size fits all, like, oh, that person's 80, we're not doing that. Oh, that person, no, she doesn't need that. Oh, we're not. Then you may want to start to find, okay, why doesn't she need it? And they should be able to show you, what the data shows or what the evidence is, not just because age is just a number. Because, as we all know, age is only a number. So if you get someone that really understands that, I think you'll be okay.
All right. Well, I hope that everyone now knows what a geriatrician is.
Yes.
The benefits of having a geriatrician. Again, thank you for joining us for this special session. If you are new to this session, this is the first time that you join this event. Don't forget to follow Royalty Senior Service Consulting on Facebook, or you can go to royaltyseniorserviceconsulting.com to learn more. We have 3 more events coming up. So if you follow Royalty Senior Service Consulting on Facebook, you will find out about the next couple of topics that will be addressed. The replay will be available, so you're welcome to share this video replay with other caregivers, family, friends, so that they can also know about this helpful information as well. Thank you again, Dr. Rogers, for joining us on today. And everybody have a great weekend. Thank you.
Y'all take care.
Bye-bye.
Bye-bye.